Hello and welcome to today's webinar, CMS 2023 Advance Notice, What Medicare Advantage Plans Need to Know. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Tom Cornfield and Matt Caminiti. Tom is a senior consultant with Avalier and provides analytical support and strategic advice for clients on Medicare Advantage risk adjustment and payment, and on Part D issues. He has over 20 years of public and private sector experience in Medicare Advantage and Part D payment policy. Tom holds a graduate degree from the University of Michigan School of Public Policy. As Senior Principal Solutions Engineer for Inovalon, Matt is responsible for the planning, operations, design, modeling, and coordination of Inovalon's solutions, including risk adjustment, quality improvement, and more. He received his Master's of Business Administration in Finance and International Business from Loyola University, Maryland. At this time, I would like to turn the floor over to our speakers. Welcome.
Great, and thank you for that introduction, and hello everybody. Hope you're having a good afternoon or morning, depending on where you're located. I'm Tom Cornfield. I'm as noted, I'm a senior consultant with Avalier, and worked on a fair number of rate notices in my day. So during my time at CMS, spent about 10 years there. So Matt and I are going to be talking about the 2023 rate notice. I know many of you are probably hard at work on your comments, which are due next Friday. So with that, let's dive into the content, and we'll go from there. And I think, as noted, I think there's a Q&A box. So if questions come up, you can type your questions in there, and then we'll get to them in as part of this discussion. So. We did the welcome and introductions. We're going to then go into an overview of what we've seen. Then talk a bit about what we've seen in the advanced rate notice. I think talk a little bit about the some of the rules. Well, let's just focus on. Sorry, I don't know if we're going to take too much on the rules. I think there may have been some rule changes, but those obviously are covered in a different regulation. Then we'll talk about star ratings, and then we'll turn to the Q&A. So what are some key policy dates for Medicare Advantage for this year and going forward? So thinking about, kind of where are we now? So we're at and by the way, I read this morning. I think it's a fun fact. Others may not think it's as amusing, but this is the last time that we'll have all the 2/2/22 until 24/22. So another 400 years for the dates to align the way they are today. So the rate notice and the proposed rule was released. Well, the proposed rule was released. Sorry, earlier, I believe I want to say in early January. And then the advance notice was released on February 2nd. The advance notice comments are due on March 4th. Again, that's next Friday. The rule comments are due on the following Monday. These are anticipated dates for the final rule. Obviously, that's not something that's set in statute. The statute does require that CMS release the final rate announcement on or before the first Monday in April, which is April 4th. But my expectation that they'll pull the rule and the rate notice together, so they'll both be released either on the same day or around the same day. Plan bids for 2023 will be due on June 7th. The open enrollment period or annual election period will begin on October 15th, and then that closes on December 7th. So these are just some of the key dates that we have going forward. Obviously, I know you're hard at work, not just on the comments. Those of you in the plan world, not just on the sorry, I know more than just plans are affected by this. So all of you that are affected in writing comments, I know you're busy at work now working on those, and due either next Friday or the following Monday. So what did we see as kind of the key provisions in the advance notice on February 2nd? And there were some changes that we noted, but there were also, I think, to some degree, it's notable for what they didn't change. And just again, to take a step back, this was the first rate notice of the Biden administration. The previous one, had been done under the previous administration. So from that perspective, this could be seen as sort of the first opportunity for them to set MA payment policy. And it largely was status quo. I think there were some slight modifications for how they calculate the normalization factor, and we'll talk about that. But that has more to do, I think, with the impact of COVID on risk scores. They did make changes to the ESRD risk adjustment model, and they're potentially talking about some changes to how they set the payment rates. One piece that's I know has been true across a lot of areas for the agency is looking for comments on how to address social determinants of health. So they're thinking about how could they address that in risk adjustment. They're also looking for comments on health equity. They did make some changes to the Part D risk model. That's primarily moving from ICD-9 codes to ICD-10 codes. So there were some diseases that were added, some that were dropped. And then there's some potential changes to star ratings that Matt will talk about. But again, with respect to where they didn't make any changes, and I think to some degree this, as I mentioned, the rate notice was notable in part for, in some respects, more for I think what it didn't have than what it did have as I think about it. There were no changes to the risk model used for MA payment, but there were also no changes for coding intensity factor or anything else associated with risk adjustment. So when it comes to what would or the rules on risk adjustment, what can be included as a risk adjustment diagnosis code for payment, CMS did not do any policy changes at all in the rate notice there. So I think in some respects it's notable for not having that. So one of the items that is key in looking at the rate notice is the bottom line, and you'll notice that this year they included a 3.5% net change associated with differential coding between MA and fee for service. I forget what they called it. I think they just called it risk score growth.
Seems like we may have lost Tom there while he's dialing back in. I can talk a little bit about some of these provisions. Hopefully, Tom's internet connection's working okay. He's able to get back in. So, as always, I think the number everyone sort of pays attention to, as Tom was saying, is, the bottom line, expected change in revenue. And it just, as always, I think we kind of point out that that's the average, right? And so the impact on any particular plan is obviously going to be, is going to be different depending on the makeup of your membership. And I think for those of you who've been doing this a long time, I think you're well aware of that. But as Tom said, there was no change in the coding intensity adjustment, no risk model revisions, which usually tend to have the largest impact on both the bottom line, but obviously also based off your entire risk adjustment program and how you work that. So. And then you can see a lower normalization change as well compared to the previous couple of years. So again, that normalization factor is, I kind of think of it as the reversion to sort of the reversion to the average based on what CMS is seeing within the risk scores as they're reviewing the data year over year. Kind of determining, similar to the coding intensity judgment, where the program is going in terms of diagnoses that are being documented, and then obviously the overall impact on risk scores. So again, a relatively, compared to some of the other years, a relatively low change in the normalization. And it looks like Tom is back.
Yeah, sorry about that.
So if you want to, yeah, no problem. I just kind of walked through at a high level, but I think you were about to make a point on this slide when we lost you. So I'll let you take back over.
Okay, I apologize about that. I don't know what happened. So Matt, did you go through the whole?
Yeah, I kind of went a little bit. Yeah, talked about the bottom line, the average overall impact, and then the relatively, as you just reinforced. I think these numbers reinforce what you were saying earlier about no major changes to the risk model, no changes to the coding adjustment. So typically the things that have a large, significant impact, on the bottom line and on how plans run their programs, no major changes from that perspective.
Yeah. So yeah, and I think hopefully I pointed out that there was this the risk score growth piece, which CMS included in their bottom line in their public facing documents of 3.5%, which is why this 4.48 might be a little bit less than what folks may have seen reported by CMS, but the 3.5% is actually pretty consistent with what CMS has had in previous years. I think in 2022 they had 3.45%, and in 2021 it was 3.56%. So if there was a change this year, it was sort of not necessarily in saying that there was what they called MA risk score growth, but rather how it was characterized in the fact sheet. Turn to the next slide. So this, I apologize. I think something got lost in the, but the pieces down here, these are the years. And so this is meant to be 2021. Hold on a minute. I'm sorry. You know what? Let me go to another slide, and then I'll get back to this slide. So these are the normalization factors. So what we see from this is that the normalization factor is, again, I'm sorry, something happened with the labels, but sorry. So the first, sorry. Let me go back to the other one. I think something went wrong with the labels on this document. So on this one, what's shown here as 1 is 2019, and what we're showing, and the blue bar is the 2020 rate announcement, and the green bar is the 2023 rate announcement. So what we see is in 2019, the the amount for that they were projecting was about $900. So that's pretty consistent. And so what happened was when CMS, the green line going down here to that point, which is labeled as 0.2, but that's 2020. That shows that spending was much lower than what CMS had projected. And then for 2021, which is 0.3 here, it was still less than what they expected it to be when they did the projection a couple of years ago. And then for 2023, this is where we kind of land, where the blue and the green line are connected, and they're essentially, or 2022, I'm sorry, that's what that is. So what's the purpose of this document? It's meant to say that the 2022 spending levels are close to what CMS anticipates for 2020, but it could very well be that if spending doesn't snap back the way that CMS expects it to be, then it could be that the spending is lower, and that could have an impact on future spending trends. On this slide, this is, and again, the labels are off, but I can verbally talk through the labels here. One second. So it's 2018. So 2018 is the 0.1.
2018, I think. Yeah, exactly where it's at.
Yeah, 2018, 2019, 2020, 2021, 2022, 2023. So you can see that a couple of years ago, the normalization factor was a little lower. Then it went up, and now it's going down. So one of the issues, and I think we see it in the next slide, which is about what would happen if they did or didn't include the 2021 data. So the line on the top line is the trend that they've used to calculate the normalization factor, and so each of those points that's shown is the risk score point associated with the risk factor. So we have a 1.127 is what they project as the normalization factor, and again, the normalization factor is essentially meant to adjust such that the risk scores will be a 1.0 in the payment year. So this is a projection. 2015 is when it's a 1.0. They expect, okay, the 2023 average risk score will be 1.127, and then they divide every risk score by 1.127, so that therefore the average risk score is 1.0. So the point of this chart is to essentially show that if they were to use that 2021 data point, it would lower the normalization factor from 1.127 to 1.075. Now, CMS is saying that they're not going to use this normalization factor. They're instead going to essentially ignore that data point. Now, I think it does raise an interesting question about what happens in 2020 if the 2022 risk score, let's say, is not consistent with what they had projected previously. Then that might suggest that the normalization factor could be lower, and CMS may have, to some degree, kind of overcompensated on the normalization factor. But my expectation is that CMS is unlikely to change their proposal of the 1.127. But I do think it bears watching what will happen with the 2022 risk score and whether or not it is on that similar trajectory that we see from the 2016 to 2020 risk scores, or if it's on a different trajectory, on a lower trajectory. So one of the key changes that we did see was they made changes to the risk adjustment model for ESRD. So they're updating the clinical version of the model to align with the 2020 CMS HCC model. They're also they're using 2017 to 2018 data now for the model calibration, whereas before I think it was 2013 to 2014. And then they're also, I think, for the functioning graft, which are people that are after a kidney transplant, they've broken that model into 4 separate model segments to reflect specific relative costs for an HCC. CMS has estimated that the changes could result in $470 million in savings to the Medicare trust funds in 2023. So I think it's notable from the perspective that it's I would imagine, a pretty significant reduction in the ESRD risk scores. I don't know that CMS has explained in much detail what accounts for this impact. I suspect it's some combination of updating the data years in the model and also perhaps adding this functional graph model. But to be honest, I think most of it is probably from updating the data years used in the model, and that seems to have had the impact of reducing the risk scores, likely because some diseases that had cost more in previous years now are projected to cost less under this new model. Another item that CMS is thinking about is changing the potential future changes to ESRD rates. So currently the rates are set at a state level, but they've also acknowledged stakeholder concerns related to payment adequacy and specifically around whether or not the rates are sufficiently are set based on the true cost of an area. So they did conduct an analysis looking at the potential impact of calculating rates at the CBSA, which is essentially the metropolitan area level, versus at a state level. And they found that the rates would decrease for rural areas, which they sort of define as non-metro areas, let's say, as 2.6%, but then would increase by 0.5% for urban metropolitan areas. So CMS is not proposing to implement the change, but they've said that they'll conduct further analysis to inform future changes. And then the agency also seeks stakeholder feedback on the potential impact of this methodology. I would point out that prior analysis from Avalere did note that in highly populated regions, costs may be substantially higher than what the payment rates are. And I think we found 10 of 15 top metropolitan areas that the cost exceeded the MA payment rate. So CMS is thinking about new measure concepts within the STAR ratings program and within risk adjustment as well. And I know we're going to turn to STAR ratings in a minute, but I just did want to point out that this is something that they're thinking about doing, which could include driving health equity, stratified reporting, a health equity index. They're also looking at refining screening and referral to services for social needs, and then measure of contracts assessment of beneficiary needs. So and I know Matt may talk about this in a moment as well. When we think about the risk adjustment model, there will be CMS is continuing to use the same risk adjustment model. So there's really no change there in terms of the risk score calculation. However, they are asking for comments on how they can incorporate social determinants of health. And I know there's been some work done previously looking at the impact of that Avalere, and I think before Avalere, I think the Inovalon had done, looking at how you can incorporate social determinants of health, perhaps at the zip code level, which I think they've mentioned as a possibility into the risk adjustment model. So they're looking for comments on how they could do that. And then they're also looking for comments on how they can improve data collection and incorporate to advance equity, as well as also to figure out how they can improve the model to include social determinants of health. For the Part D program, the parameter changes, these are pretty standard, so I won't spend much time talking about them. They are adjusting the model to include some additional condition categories there. I think it's a net of 8 additional categories. They're updating the data using 2018 claims data and 2019 expenditure data, and then the model is estimated on ICD-10 codes instead of ICD-9 codes, which may account for some of the clinical changes that they've made. So with that, let me turn it over to Matt, and then he can walk you through the star rating changes. So Matt.
All right, sounds good. Thank you, Tom. It is interesting. I think a lot of the changes that Tom talked through, flow into sort of the way CMS is thinking about the star ratings as well, particularly around the inclusion of social determinants of health. The sort of getting away a little bit from just the clinical type measures that they've had in the past, where you get this immunization or this test done, or does an individual fall into a certain clinical measure, but they're more increasingly looking at how does the overall patient care reflect on how well a plan is sort of treating their members. And so we've seen that the past few years as they've increased the weight for the CAPS measures and the other, patient experience measures, where I think that, accounts, I believe somewhere around 40% of a plan star rating now is determined by these survey measures. And so, it's a little bit, I think as clients have been talking with us, they're looking more and more at not just, again, how do we get this individual compliant with a certain measure and get these immunizations done, but how do we stay engaged with our members throughout the year so that when these CAP surveys come along at the end of the year, the individual has a positive view of how the plan treated them. So even if they saw the types of things you need to think about, or even if that your individual had filed a claim back in February, if there's 10 months before they get that survey, how do you keep them engaged and ensure that they are have a positive view of the plan? And I think those are the types of things that it's a little bit more difficult to keep that sort of engagement with the members throughout the year. So, but clearly CMS is continuing to have that, those survey measures as an increasing part of a plan's overall star score. So, certainly no indication that any of that's going to change or that it's going away. The other program level change, so we had talked in our previous year's notices about the guardrails. So they had put that on hold due to the pandemic, but basically they are going forward with the guardrails, or proposing anyway to go forward with the guardrails that they had proposed previously, essentially ensuring that the cut points aren't straying too far high or low, year over year as they're adjusting, those cut points, so that hopefully gives a little bit more predictability to the plans, even if, an individual cut point on an individual measure may have a positive or adverse impact. Again, the guardrails, I think the intent is to provide a little bit more predictability, both for CMS and, obviously for the stakeholders and the health plans. On the measure level, the removal of the rheumatoid arthritis management measure. There's a couple of measures related to statin use and in persons with diabetes, and then the controlling blood pressure measure is going off the display page and becoming a new star measure. So will now be factored into the plan star scores. A lot of these, I think, similar to the risk side, nothing, I don't think, no bombshells, so to speak, in terms of major changes to the program. So similar on the risk side, as Tom said, it's commenting on about what the CMS didn't do. I think similarly on the quality side, a lot of those changes we talked about and some of the changes coming up are things that CMS has been alluding to for a number of years. So again, I don't think there's any huge surprise or huge impact. Won't go through all these the slides. You can contact us after and we can provide the slides from the webinar so that you'll have them as a reference. So obviously not going to go through each one of these measures, but did want to point out a couple changes in a couple different places. So again, the complaints about the health plan. So they're looking at feedback on whether to adjust the calculation for this measure. Obviously, that's one of those measures that's not really clinical, but is more related to a survey measure. So again, signaling CMS's direction toward, kind of looking at that patient experience. And then the adjusting in one of the few clinical measures they are, sort of making a potentially significant change is on the colorectal cancer screening and adjusting the age, downward so that it's bringing additional individuals, essentially into the denominator for the measure by updating those guidelines. And then you could see a few other measures on this slide where, NCQA is sort of considering some changes or exclusions and how they're thinking about them. And so those are the types of things, as usual, they're sort of looking for commentary on. As of now, no sort of major, obvious impact, but, certainly as comments come in, they'll, potentially could be depending on how they eventually may implement any kind of changes to the different measures. On the Part D side, again, just a few different kind of considerations. The statin use in persons with diabetes that we mentioned earlier. So again, a little bit of the adjustment in the definition of this measure from the PQA, the Pharmacy Quality Alliance. So just again, sort of noting that that's again something that they've sort of signaled in past years. And then again, looking for some feedback on some of the med adherence, and then the MPF price accuracy measure as well, which I think we note in a couple of different places in the presentation here. So you do sometimes see, CMS makes changes to the CAI. Again, no changes to the index. We mentioned the removal of the rheumatoid arthritis measure, but again, no major changes this year. I mentioned previously for the improvement measures, the MPF price accuracy measure. So again, that's as a reminder, the sort of the difference between what the plans are publishing on their website as the cost of drugs compared to what individuals are actually paying. So again, that's sort of where the MPF price accuracy index or calculation, that's where that comes from. And then a few, on the right-hand side there, there had been the past couple of years due to the pandemic, and then before that due to some major natural disasters that were occurring in different parts of the country. There were, a number of different, obviously, changes and some things that were put on hold. Obviously, last year allowing plans to choose, the better of the 2 years for their star ratings. Some of those major, sort of changes. We're kind of back into normal now, as far as what they're proposing for the most part with 2023, but. They did note that they're proposing to remove the 60% rule. So that's if 60% of your members are within a disaster area, that you'd sort of be excluded from certain measures, calculation of certain measures. So they are proposing to remove that threshold, which would again sort of allow them to essentially do a more kind of traditional calculation for those particular measures. And then again, won't go through all these every year. As you know, CMS is sort of proposing new measures that they may or may not include in their star rating. So they move them to the display page. So you can see a few of them listed there. As they've signaled in the past, there is this focus on opioid abuse and use of opioids and prescribing of opioids. So, there's actually a couple different, sort of measures or measures that they're looking at in terms of opioid use and prescribing patterns that they're looking at, potentially including. Is that still, certainly a national focus and has been for the past few years. So again, kind of noting that as some of the policies that they are continuing from, the previous administration, as Tom said, and, sort of some of that consistency that they've had year over year, in the star ratings. So again, a reference point, but as you as a plan are thinking about, how you're treating the members, how you're addressing these certain measures. Obviously CMS is signaling these are the types of things that could potentially have a direct impact on star scores in the future. So, always kind of a good place to look to see, even more generally, what is CMS thinking? And as Tom noted in the risk adjustment section, they are looking at a lot of these sort of social determinant type measures, and focusing more again on kind of I would almost call it like the whole person care, in terms of, again, looking at surveys, social determinants, as well as the clinical measures. Here we go. It took a second to change there. So again, these are some of the specific things they've noted in terms of kind of that focus on social determinants, which again is not just the CMS policy, so to speak, but is something that I think in general we're seeing around the healthcare industry. It kind of pops up every once in a while. It does seem to be a little bit more sustained, I think, more recently. And this is starting to make its way into some of the things, again, CMS has been signaling, really for the past couple years, but they're starting to put some additional detail. Tom had mentioned, in particular, the Health Equity Index. So it's sort of looking at, how does the care and the behavior and things like that change based on things like geography and how are different measures, performance on different measures different based on, again, geography and race and access to care and things like that. So I think it's a little bit more, certainly there is a quantitative way to calculate some of these things, but there is a little bit of a sort of qualitative component as well. And so it's something that I think, taking advantage of CMS asking for that feedback, and especially for if your plan is treating or serving individuals in that have sort of a wide variety of circumstances that they're coming from, I think providing that feedback now, as CMS is starting to look at developing these types of indices and measurements, providing that feedback on what's the best way to do that, again, given that there is sort of a quantitative and a qualitative component to that. And Tom mentioned some of the research that Inovalon and Avalere has done on that in the past. And then finally, similar, to what we talked about with the display measures, CMS always adds in some new measure concepts that they're looking at and looking to get feedback. Again, to their credit, looking to get feedback on some of the additional measures that they're thinking about. So you can see some of those listed here. So additional diabetes care, controlling blood pressure. Tom mentioned some of the value-based care concepts, that CMS has been alluding to. Obviously, value-based care type arrangements are becoming more common, that we're seeing, where there are providers taking on certain downstream risk, and you as the health plans, as you're working with your provider groups and contracting and providing incentives. I think CMS is recognizing that that's where the industry is going, and then looking for feedback on how can this be measured? How can you sort of, as a health plan, get credit for the types of arrangements that you're putting in place? So certainly, again, something that CMS is signaling that they're watching where the industry is going. And then you could see a few other listed there, and then of course additional caps, continuing focus on caps. So some additional caps type measurements that they've noted as well, where they're looking for feedback on the types of questions they're asking, and how that's factoring into the overall star rating calculation. So again, as you're thinking and developing those comments, as you're thinking about, not just responding to what CMS has directly proposed, but providing feedback, taking the time to potentially provide feedback on some of these broader areas where CMS is looking to, potentially go in the future. So certainly something to think about as they signal in a certain direction. All right, so that covers the content. Again, I think nothing necessarily too revolutionary in this notice, which is good. But I think CMS is trying to provide some predictability and again, I think the bottom line, sort of that focus on some of those non-clinical type, type measurements of how the plan is performing. They're continuing to move in that direction. So I'm going to look. It looks like I think some of the questions we probably have answered. I think as we went through. There is one question, and it may actually address it a little bit offline. It's saying provide some insight into what kind of complaint would be routed into the category 1.3. So this is one of the first provisions we had talked about. Yeah, I don't know that. I mean, unless Tom, you have any kind of initial thoughts, that might be something we could maybe follow up with offline as we think about it and talk to some different folks around the company.
Yeah, I mean that particular complaint I think has to deal with inappropriate marketing by plan representatives. So I suppose the way I think about it is something that a misrepresentation associated with misleading marketing materials and or the marketing staff is not expressing, not making it clear to the enrollee, so they're getting a complaint about that. So
right,
and
yeah,
there's some more technical pieces to it, but I think that's kind of the key question. Go ahead, sorry.
Right. No, I was just going to say I agree. Yeah, I don't know that CMS has signaled, how specifically, what type of specific, if they sort of defined it, I guess, exactly what type of complaint, that would be. But I think you're right, Tom, at a high level, I think anything around, that misleading type information, but how exactly they would measure that or what the criteria would be. I'm not sure they've signaled yet. But again, that would be an area to provide feedback. If they are going to go in that direction, what would be a reasonable, perhaps threshold, or how do you define what's misleading and things like that. So I think as the plans and other stakeholders are thinking about your comments and your feedback, I'm sure CMS would welcome your experience and some feedback on that. So I think I don't think we have any additional questions that we haven't answered. Certainly our contact information is here on the slide. So if you do come across something, or as you're sharing the information with your colleagues, if there are additional questions come up, or you want to dive deeper into a certain concept, certainly we'll be happy to do that. We will also be at on the conference circuit sort of in the spring, as we're getting back to in person. So RISE and AHIP has a couple conferences coming up, so we will have representatives there. So feel free to engage us live as well. It'd be great to see folks again. So we're definitely looking forward to that. All right, and so I think we're good. So thank you all again for for attending, and like I said, we'll you can follow up info@inovalon.com for a copy of the slide deck, and again, happy to follow up on any of the additional questions that might come up. So thank you again.
Thank you for that great presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. This concludes our presentation, and thank you again, and enjoy the rest of your day.